So I will take the liberty of introducing Zahid, who actually I know him when he was not in medical school, but he finished his medical school from University of Saskatchewan, and he's gone to much bigger things. He has done multiple trials. He's a principal investigator in what is now called the ACCLAIM trial. He's the past chair of the Department of Medicine at St. Thomas and Elgin General Hospital, and he has been a board member of London Muslim Mosque. And inshallah, he's going to be telling us today about current management of diabetes. Thank you.
Bismillah ar-Rahman ar-Rahim. Wassalatu wassala Rasulillah. Thank you for that kind introduction, and also thank you for the organizers for inviting me. Can you hear me okay?
Yeah.
Okay. We'll see how this works now. First of all, I have to make some disclaimers. I'm not an endocrinologist and I'm not a diabetologist, but you could say I was coerced into this talk. Okay. So inshallah, I'll do the best. Also, I'm not going to be talking about type 1 diabetes. And I'm going to try to focus on these new therapies because I think they have a tremendous potential both in heart disease and also renal disease and other potential benefits. So I do have some disclosures. They're up there. Basically for this talk, there really is not a lot except that some of the drugs that I will mention are by pharma that I have received support from before, specifically BI, Novo Nordisk, and Novartis. Now, in terms of how to mitigate any potential biases, I'm just going to rely on Diabetes Canada and CCS guidelines. And I also have some colleagues here who will call me out if I say anything. The rest of the stuff that I will do, I will give you some clinical pearls to take home. Now, the learning objectives are that I'm going to give you a quick snapshot of what diabetes prevalence is in Canada. And then we will very briefly now, because in the time allotted, I cannot go into much detail, but I'm going to talk about some of the diabetic criteria. Also, I'm going to focus on our community, the South Asian community, and I'll make some comments there. We will talk about the newer therapies in more detail. And then I will talk briefly at the end about some cardio-renal protective strategies that I think are very important. Now, diabetes in Canada, every 3 minutes a Canadian is diagnosed with diabetes. So we can say that, it's about 30% of Canadians living right now who have diabetes. And I actually think that this is going to really mushroom and balloon. The reason why I say that is that I'm sure you know, we've had quite an influx of people of South Asian background who have come, thanks to the Liberal government. I will make some comments about that later on. So I think that number is going to exponentially increase. Now, in terms of the prevalence, you can see here from going back from 2000 to 2024, that line is a straight line. It's still going up. This is for type 2 diabetes. For type 1, you can see it's a level playing field. Now, having said that, I'm actually very excited because there are a lot of pharmacotherapies that have come on the stage. And also, we have new ways of monitoring diabetes. So I'm specifically referring to CGM, continuous glucose monitoring, but also the therapies that are out there. They are significantly impacting both not just diabetes, as I said, cardiovascular disease, renal disease, and actually obesity management. Now, I think it's very important if we can, this is a website and this is an organization that I think is very helpful, both as practitioners and for your patients. They have excellent screening tools, self-monitoring tools. So it's something that you should really familiarize yourself with. Now, just to put it into context, if I were to ask you, what's the most important goal for diabetic management? And a lot of these things, so is it strictly looking at numbers and trying to getting people to target, which we do? We do that all the time as clinicians. Is it to resolve and get rid of symptoms that patients have? Is it to reduce the diabetic complications and the risk of people getting diabetes? Is it to attain glycemic control, durability? What we mean by there is excursion of glycemic control. Do we try to reduce that excursion? Do we avoid hyperglycemia at all costs? Now, a lot of those questions will look, the answers look like they're all correct, but there's one in specifically that we should really concentrate on. Now, this is the reason why we concentrate on that specific issue, is because diabetes has significant impact as it relates to something that I have a great interest in, cardiology and cardiovascular disease. 40% of MIs can be attributed to diabetes. Stroke, we know we have, mashallah, a lot of stroke physicians here, and they will attest to that. Also, patients going on to renal failure, requiring dialysis, 50%. Non-traumatic leg and foot amputations. If you ever seen somebody who at end stage has diabetes and has to have a foot amputation, you can imagine, what that is for that patient and the family around them. It's a leading cause of blindness, reduces lifespan of a patient. And also, in terms of healthcare dollars, these patients are the ones that come into the hospital again and again. They get readmitted, whether it's for heart disease, for kidney disease, stroke, or lower extremity ischemia. Now, I'm not going to go into this in detail, but this is something bread and sort of butter that we all know about. Diabetes can be classified into the complications into microvascular and macrovascular. You would note that the brain is at the top here, Ashfaq, and the heart is below, okay? And I actually remember, this is a story, this is when I was in med school, Ashfaq came up with the idea. He was saying that, everybody knows about a heart attack and people don't take much consideration about people who have a stroke. And he wanted to call it a stroke attack, but it never flew. Do you remember that? I still remember that. Okay, so you have basically microvascular that affects the eyes, the kidneys, and neuropathy, and the brain, as we know, stroke, TIAs, dementia, and heart, basically coronary disease, high blood pressure, and the extremities I've talked about already. Now, there are risk scores that you can look at that can help you to decide where your patient is. One of the risk scores is this diabetic risk questionnaire, CAN-RISK. There are others also. Now, this is one thing that I wanted to kind of emphasize based on the population that we see and we serve, the South Asian community. There have actually been studies done to show that they have a higher incidence of diabetes. And a lot of it, sort of, the studies are coming to bear that it's due to the abdominal obesity, insulin resistance, and the metabolic syndrome. And there are both genetic factors and, I would have to say, lifestyle factors. And we really need to work hard on these. A lot of it, in terms of the other factors, is basically a lot of lack of knowledge about diabetes. I'm sure when you try to counsel patients from our community, they don't regard lifestyle in terms of diet or exercise as very important. I've heard this comment made that if we don't have samosa or pakode iftari nahi hoti, right? So same thing with parothe in the morning, then you don't have the suhoor. So it's like this is mindset that we have to eat specific foods, otherwise we're not getting the calories that we need. This is in England. They had developed this scheme here to say that the South Asian community has 6 times more likely to develop type 2 diabetes than the white Caucasian population. So this is something that I think you as clinicians need to make sure and work harder on our community. Now, having said that, when I said that targets don't matter, this is one way that we can gauge where the glycemic control is in our patients. And the comments that I'm going to make here is that what I see is that there's a bit of a clinical inertia in the sense that when patients are around 7, the GPs they don't go any further. They don't try to optimize or reduce the A1C further. And actually, the data shows that the risk is a continuum. It starts, actually, some people even say around 6 or even a bit earlier, and it starts to go up. And I'll show you a graph about that. So it's very important that, particularly now, because the drugs that we're going to use cause a low risk of hypoglycemia. We used to worry about before that patients would get hypoglycemic, so we wanted to stay around 7. But no, what you should try to do is get people to less than 6.5. I have seen in my practice patients who have had coronary disease, who've had MIs, with A1Cs around 6.3, 6.4, with other factors controlled. So glucose is toxic to the endothelium. And actually what I like to think about, I know we categorize stroke and heart disease separately, but if we think about it as a vascular risk and vascular disease, it's at the level of the endothelium that the glucose, the sugar, is toxic. And we talk about now endothelial dysfunction. So obviously, if you have a patient who is older and there's more risk of hypoglycemia, then the restriction on the A1C is going to be more liberal. And obviously, if they're older, they're in their end of stage of life, you're going to be more liberal with the A1C. This is just a graph to show you that the risk is a continuum. It's not a specific number. And obviously, as you go higher, the risk becomes more. This is just a quick summary of the screening and diagnosis. Number of risk factors that I'm sure most of you know about. Particularly, I also make sure that women patients that I see, I ask them about gestational diabetes. If they've had babies that are large, they're at higher risk of getting diabetes. Now, in terms of who to screen and when to screen, I'm not going to go into detail. Everything is there, and I'm sure most of you know. But it's important, the basic take-home message is that if you have patients who have a lot of risks, you need to screen more often. And you need to make sure, because the sooner you get them identified, then you can treat them sooner. The two ways of doing it is the fasting plasma glucose and the A1C, and it's listed there. I myself, actually, I'm quite stringent. When I see someone who is a pre-diabetic, I right away start thinking of incorporating lifestyle measures. And depending on the patient profile, if they're very obese, off record and off label, I've actually used SLG2 inhibitors to try to get the weight down and then also get them exercising more. Now, in terms of the oral therapeutics, as I have said already, it's very important to look at the holistic patient. You need to see what kind of other risk factors they're coming with. Now, I'm not going to go into any detail because we don't have time, but generally the first line of treatment is still metformin for type 2 diabetics. It's a drug that's been around for a while, is a good safety profile. It does have a low risk of hypoglycemia, and actually it does cause some weight loss in patients. The biggest downside is that there are GI side effects. Typically, patients will talk about nausea, metallic taste in their mouth, and they will get looser bowel movements. Now, sometimes I even ask them, are you constipated? And I'll actually put metformin on to try to, counterbalance that. There's one class of drugs that you should probably withhold or not use, which is the sulfonylureas. And there is some negative data even for cardiovascular health. And I would say that if you have to use it, dimicron is probably the one to use, and don't use glyburide. Now, this is a picture of London, Ontario. So I haven't been paid by the City of London to do any of this marketing, by the way. But it actually reminds me a lot of Saskatoon. And I think maybe that's why I ended up there. And actually, we have a 1-2 punch. I'm from London, and Sadia's from London too. So, all right. So I'm going to give you a few. There's a lot of acronyms and abbreviations out there, and they can get kind of confusing. So the SLG2 inhibitors, it stands for sodium glucose cotransport 2 inhibitor. You can see why we need an abbreviation. It's so long. And then the other one is the GLP-1 receptor agonists. These are glucagon-like peptide receptor agonists. That's what it abbreviates for. I'm not going to talk about the last one that's called DPP-4 inhibitors. Now, quickly, just to get into the meat of the talk here, the SLG2 inhibitors. And just as an aside, I remember sitting in a conference listening when these drugs first came out. And I said to myself, what a crazy mechanism this is. This drug is going to make you pee out sugar. You're going to get infections. And, who's going to take this drug? I remember sitting there. And lo and behold, now you will see they turn out to be one of the best drugs for diabetes. So basically, there are three drugs that are available in Canada: empagliflozin, dapagliflozin, and canagliflozin. And actually, I was outside there, and the drug rep, she came up to me and she said, "Do you remember me, Dr. Sardar?" And I said, "No." She said, "I used to call on you for Invocana 15 years ago." And I said, "It was amazing." And she just met me outside. So actually, Invocana came out first, and then empagliflozin, dapagliflozin. Out of all these three, empagliflozin is still not generic, so it's branded. The other two have become generic. So if you have issues with patients not being able to pay and they cannot be covered in Ontario, you might pick one of the other ones. They do cause weight loss. So this is important. So if you have a patient who's overweight, out of those two, I'll show you a bit of the studies. EMPA and CANA, just to abbreviate them, they do lower CV mortality in high-risk patients with atherosclerotic heart disease. And as I will show you, and I will sort of pound this into you, we use them in HFrEF, which is heart failure with reduced ejection fraction, because they help to reduce heart failure hospitalizations and also, cardiovascular mortality. While they say here there's a contraindication below -30 eGFR, actually empagliflozin has been studied lower than that. So you're okay even up to -50, less than 15 or around 15 millimeters, less 50 mils per minute. So while we don't suggest you start them with that low, but you can go down and it's relatively safe. The side effects is that they do cause what we call acute kidney injury, which means that you're going to get a rise in the creatinine, but it's actually quite short-lived. And when they look at the graph long-term, it actually benefits the kidney. You do get more GU, that's genital urinary infections, typically mycotic infections, and I will counsel my patients, both the male and female, how to avoid those. There is an entity called euglycemic diabetic ketoacidosis that can happen. It's very rare. Typically, I'll show you later, there's a thing called SAD-MANS. If you go through that with the patient to let them know when they should hold and not hold therapies. And while it says here that canagliflozin was shown to cause increased lower limb amputations, actually the more recent meta-analysis shows that this is not the case. Like when you put them all together, they don't see that as particularly higher risk. Neither are bone fractures shown to be at higher risk. Now, I think it's important just to quickly to understand the mechanism. So the mechanism here, I'm not sure if there's a pointer here. I don't think there is. Okay, sorry. Okay, here. So basically, if you're looking at this is a renal tubule. And generally what happens normally is that the glucose and the sodium is reabsorbed, okay? And the SLG2 inhibitor, the co-transport's right here. When we inhibit this is going to cause glucose and sodium to go down. So you're getting a natriuresis and a glucosuria. You're getting rid of glucose, okay? This happens, actually, there are two receptors, the SLG2-1 and the 2. The one is predominantly the one that does that. 90% of the glucose is reabsorbed by that receptor. Now, this is quite interesting because they found that when we do that, and this obviously studies are ongoing, not just the glycemic control. The glycemic control is very modest. You don't reduce A1C a lot. But what we do find is that the kidney benefit, we think, accrues from the reduce in interglomerular pressure. So you have the nephron and you have the pressure. If you're able to reduce the pressure over time, that's protected for the kidneys. But as I said, you can expect about maybe sometimes 10% drop in the eGFR when you first initiate. So don't get worried. You're going to see that dip in the eGFR and the worsening of creatinine. Other things that we notice is that you're going to get a lower blood pressure because they actually act as a diuretic. And what I do is I always look at the other drugs. Oh my gosh, just tell me I have 1 minute left. You have other drugs that you're on board, so you make sure that you don't want to cause hypotension. So I tend to either reduce or eliminate the diuretics and look at the other drugs that they're on, antihypertensives, and I will modify those. And I'll let the patient know what to expect. It's like I got to get going here. So this is just a picture of Springbank Park in London, Ontario. So I think I'm going to, just because I'm running out of time, I was just going to mention a couple of the trials. The EMPA-REG trial was the outcome trial that really put SGLT2 inhibitors on the map. And I'm just going to go down to the outcome summary. So it reduced 3-point MACE, and MACE is basically major adverse cardiovascular events, by 14%. And things that we didn't expect, it reduced cardiovascular death by 38%, mostly by reducing heart failure hospitalizations. It reduced all-cause mortality by 32% and hospitalization, as I said, 35%. There was some increased genital urinary infections. I'm going to skip this. There have been other trials that have happened, and there's been more trials. So basically, when they've used all the different types of SGLT inhibitors, they find that for the most part, they do roughly the same thing. Obviously, when they do different trials, they have different inclusion, exclusion criteria, so you cannot compare them. But in general, what I like to think about is, and just based on the evidence, I will use empagliflozin more for cardiovascular and heart failure reduction, and I would tend to use DAPA more for renal, and then actually there's a bit more weight loss with canagliflozin compared to the other ones, just in a nutshell. So this is another picture of London Western University. Now, quickly switching to the GLP-1 receptor agonists, they're also called incretins. The ones on the market, I'm sure everybody's heard of Ozempic, and then there's Trulicity, and Wegovy is actually just a higher dose of Ozempic, so don't get confused. Wegovy is Ozempic, just at a higher dose. And then we have Mounjaro, which is a new kid on the block. I was going to go through this, but I suffice it to say that they work at, this is how incretins work. They cause increase in insulin production and decrease in glucagon. I'm not going to be able to go into all this, but basically the mechanisms. Now, this is very interesting. Even though we're talking about diabetes and we're talking about improving glycemic control, they're finding now that the GLP-1 receptor agonists are working at the brain, and they're actually looking at this even for dementia to see that, and there's clinical trials ongoing. There seems to be neuroprotective benefits, cardioprotective benefits for the heart. And basically, the way it really works, how GLP receptor agonist works, is that they slow down the stomach. Basically, you get gastroparesis. That's why there's concerns about having these drugs on board when you're going for surgery. So they slow that down. Now, when we actually eat, that's what the human body does. In order to get the most absorption out of the food, we get GLP-1 secreted normally. This just helps to augment that process. So you're basically augmenting something that's already happening. I was going to go into this, but the trial that put Ozempic on the page was Sustain 6. And I'm just going to go into this. This is a meta-analysis that was done. GLP-1 receptor agonists, regardless of structural homology, in other words, regardless of the type, reduced the risk of individual MACE, all-cause mortality, admission for heart failure, and kidney disease. So you can see by this that there is an element, and now this is what this graph is trying to show you. So grade A evidence, before you were saying that if you have somebody with atherosclerotic heart disease, you should preferentially use that drug for if you want to reduce MACE, heart failure, and basically you would use SLG2 inhibitors if you had concerns about reducing nephropathy. That's what it was before. Actually, and as more and more trials are coming out, they're actually finding that GLP-1 agonists also have benefit in progression to kidney disease. So this is as we go along. Now, the other thing, I'm just going to mention this slide. Whether you're a diabetic or a non-diabetic, these drugs seem to have benefit. And this is what more trials are coming out. So imagine you come out with a drug that you wanted to use for diabetes. All of a sudden, it has benefit in heart failure and cardiovascular outcomes and, renal disease. And now it looks like that there is this element, and we're going to see maybe this synergy that is going to help all these domains. So this was from the CCS. They talk about that if you wanted to initially think about CKD, you would look at SLG2 inhibitors and heart failure. But now, as I said, there is also data to show that GLP-1 receptor agonists also benefit this patient class. And if you have somebody with multiple risk factors and established atherosclerotic heart disease, you would think of GLP-1 receptor agonists first, and then maybe add on SLT2 inhibitors. So basically, I think I've mentioned all this. I'm just going to go quickly just to the mitigating factors that you might want to do to when you have these patients. Is I counsel patients on, if they're using SGLT2 inhibitors, making sure that they, actually this is part of our DEAN. We have to wash ourselves after we use the bathroom. Now imagine that this is now a strategy that we should be telling our patients that after you go to the bathroom, because what happens is when you pee out sugar and humidity is a very good nidus for bacteria and fungal growth. So if you can get them to remain clean below there, either using wipes or water, you're going to minimize the risk of them getting GU infections. Plus, I also counsel them to drink more water, to make sure they hydrate themselves, because by using SLG2 inhibitors, you're causing an osmotic diuresis. You're going to become deplete in volume, okay? Now, other things that we talk about, there's this SAD, sick day protocol. There's a list of drugs that you should tell your patients to avoid and hold before either a surgery, but also if they get sick, any nausea, vomiting, diarrhea, you hold these drugs. I think that's very important. Making sure that, you do a foot exam. And basically, if you let them know ahead of time that these are expected side effects, you can avoid them. Now, just this is the last slide here. I know I'm out of time. I hope that I've shown you that diabetes, but not just diabetes, but the other multiple risk factors that we talk about, it looks like there's a synergy where we're finding that, these drugs, and I think more to come, they're going to be beneficial, and it's getting a bit more complex. So if ever you want to refer to your friendly internist or cardiologist, feel free to do so. But at the same time, I think it's very important for family physicians to get well acquainted with these drugs and to use them. And the only way that you're going to get comfortable is to use them. I know initially when they first came out, we would get the drug reps and they were saying that there was a very slow uptake, particularly for SLG2 inhibitors by the GPs. And, they were worried. But I think now, as time has progressed and you have seen that the studies have come out and the evidence is there, I'm hoping that you will use them and get comfortable with them. If you have any questions, I'll be happy to answer them later. Thank you.